Along with the development of EGFR drugs has been the development of our understanding of what can cause resistance to these drugs, both through preclinical studies as well as many patient biopsies. We as a field have understood a picture of what causes resistance to these drugs. And one of the main players, especially with some of the newer third-generation drugs, is MET amplification. We know that MET amplification can come up as a bypass pathway and cause resistance to EGFR inhibitors. And from preclinical experience, we know that the best way to attack these cancers might be to combine both an EGFR inhibitor and a MET inhibitor together. It looks like either drug alone would not be sufficient, but when you have a combination, you can really attack this resistance pathway. The TATTON clinical trial that I presented at AACR this year looks at patients, EGFR-mutant patients, that have MET as an acquired resistance mechanism and treats those biomarker-selected patients with a combination of an EGFR inhibitor, in this case osimertinib, and a MET inhibitor, in this case savolitinib. The preclinical work that looked at MET as a bypass or resistance pathway really suggested that you would need to have both of those components together in order for the treatment to work. And there have been prior clinical trials in lung cancer that have looked at that combination of an EGFR inhibitor and a MET inhibitor, but unfortunately those trials were not done in a biomarker selected population. So this is really the first clinical trial using the combination of two drugs in the population that has that biomarker signature. So it's exciting to see that this concept can work when you apply the selected patients.